Hello everyone, this is Dr. Hashem Abu Serhan. I am here today to talk about new hope, new horizon in management of one of the dismal prognosis diseases in ophthalmology. I will talk about the efficacy and safety of intravenous prostaglandin E1 in the management of retinal artery occlusion, mainly the central retinal artery occlusion, a systematic review we have done. So I don't have any disclosures to declare in this presentation. Our paper was published in the Journal of Retinal Vitreous Diseases, Retina, which is a Q1 journal and one of the top journals in retina field. I was honored to be the first author of this paper, and it was just published in last March, 3 months ago. Also, I had the privilege to present our talk in the last Retina in Spain. We talked about the findings of our paper. So, as an introduction, retinal artery occlusion, including both the central and branch retinal artery occlusion, is an urgent ophthalmology condition, and it's considered the stroke of the eye. As you know, 80% of those affected have a visual acuity worse than 20/400. And the American Heart Association has a scientific statement about the management of central retinal artery occlusion because it considers retinal artery occlusion as a stroke, as we told. Central retinal artery occlusion or retinal artery occlusion is a very big challenge. For example, in one of the studies published in JAMA Ophthalmology in 2016, 2,000 adult respondents in one of the questionnaires, around 88% of them viewed eye health as critical to overall health, and 47% rated losing vision as the worst possible health outcome, even worse than losing hearing, memory, speech, or limb. And in a similar survey, 70% of them, of the adults, ranked loss of eyesight as 10 out of 10 in terms of having the greatest impact on daily living. Actually, one of the studies showed that the rates of depression and anxiety are significantly elevated among people with severe visual loss. And this is the graph showing that losing the vision and blindness is considered as a worse condition, even worse than Alzheimer's disease, cancer, AIDS, loss of a limb, heart disease, arthritis, or deafness. And it's also showing that losing eyesight is having the greatest effect on daily life, comparing with losing memory, limb, speech, or even losing hearing. So the current practice, unfortunately, is very limited. The success rates of current management options like ocular massage, like paracentesis, like aquasuppressants, tissue plasminogen activator, remains very limited. But on the other hand, however, there is always hope. And there is prelim reports show that prostaglandin E1 could enhance the ocular blood flow and visual outcomes in patients with CRAO or PRAO. We do have a knowledge gap. That's why in this systematic review in our paper, we aim to evaluate the existing literature about the effect and safety of prostaglandin E1 in management of retinal artery occlusion. So our methodology was rigorous, like any systematic review and meta-analysis. Our protocol was prospectively registered on Prospero. We searched multiple databases, including PubMed, Scopus, Web of Science, Google Scholar. Following Prisma recommendation, we exported all the records from databases. We put them in no software. Then we applied our eligibility criteria. We did the first screen, the second screen. Then we did data extraction through Excel sheet, and we assessed the included studies, the quality of them through GBI critical appraisal tool, and we conducting many tests, including Wilcoxon rank test, to see if there is any significance of using prostaglandin E1 on the visual outcome. So now coming to the results, to the most interesting part. We have total of 6 studies. We analyzed them both qualitatively and quantitatively. 3 of them were case reports and 3 of them were case series with a total of 21 cases. As we know, CRAO is very not that common and very limited data about it in the literature. So we have a total of 21 cases. We pooled all the cases, and the studies were conducted mainly in 3 countries: Italy, Japan, and USA. The age of the included population ranged from 45 to 97%, with a mean of 65 years. 10 of them were females, 11 of them were males, and this is the Prisma flowchart. So as a baseline, CRAO represented 85% of the cases, while 15% were branch retinal artery occlusion. The median time from symptom onset to the presentation or treatment initiation was 7 hours, which is a very important period. Prostaglandin E1 was given mainly IV, and the initial dose, median initial dose, was 40 microgram with a frequency every 2 days, and for cumulative days of 320 microgram, and the median duration of treatment was 4 days. So the efficacy, all cases, which is very important, all cases showed improvement in visual acuity after treatment with IV prostaglandin E1. Interestingly, 2 cases out of the 21 cases showed regaining full vision of 6 snellen or 0 logmar. And the median change in visual acuity before and after the treatment was minus 1.3 logmar, which means there was improvement 20 letters in ETDRS scale. See, this is a huge improvement. Now that you don't see this in any other treatments in prostaglandin and CRAO. And Wilcoxon test, which is one of the non-parametric tests, revealed significant improvement in visual acuity after IV prostaglandin treatment. Regarding the safety, there was no major adverse events reported in all included studies. One of the studies just reported extensive, one of the studies published in Case Reports in Ophthalmology in 2023, reported extensive inner retinal edema after 2 weeks in one of the cases due to possible ischemic reperfusion injury, and was managed successfully with giving steroids. Also, one study reported only pain on injection during the IV injection of prostaglandin E1, so it's considered as a safe treatment. So coming to the discussion, we saw that it's safe and efficacious. How prostaglandin E1 improve the vision in patients with CRAO? Mainly through 3 mechanisms. The first mechanism is vasodilation. We know that prostaglandin E1, one of the major uses is to keep the ductus arteriosus patent in children with congenital heart diseases, to maintain this ductus arteriosus patent so they can stay alive until they do surgeries. And also one of the major uses is the use of prostaglandin E1 in the peripheral lower limb ischemia, because vasodilation and improve the perfusion of blood flow. So it has vasodilator effects, and these vasodilator effects most likely contributed to the therapeutic benefit we observed in our systematic review. In addition to that, one of the studies discussed that prostaglandin E1 showed transcriptional effect, and these transcriptional effects provide protection against ischemia. So it has not only vasodilation effect, also transcriptional effect that protects against ischemia. In addition to that, not only that, prostaglandin E1 in one of the studies showed that it can inhibit the monocyte and neutrophil function, which might suggest anti-inflammatory effects. So we have three rules, three mechanisms: vasodilation, anti-inflammatory, and transcriptional effect. Through all these three mechanisms, vision improved in CRAO, BRAO cases with IV prostaglandin E1. Regarding therapeutic window, as we know that we have critical therapeutic window for retinal artery occlusion because it's a retinal ischemia and there is always time to inject. So the TPA, one of the medications used, tissue plasminogen activator in CRAO, it has narrow therapeutic window, which is 4.5 hours. However, in our study, it showed that the median time from symptom presentation to treatment initiation is around 7 hours. And many studies mention more than that. But in general, it has almost double the therapeutic window of the TPA and much more safer. We all know the complications of tissue plasminogen activator. So it has wider therapeutic window. Coming to the limitation, no studies in the literature has only strength without limitation. This is the normal of the scientific papers. Our review relies mainly on case report case series because of the rarity of the condition, but its limitation. This study design very important, very valuable in the early stage research to highlight the novel treatment and generate hypotheses, but they have limited ability to establish the causality and they have high chance to bias, and also there is lack of generalization of the findings because of the study design nature. In addition to that, published study included in our analysis, it can represent cases of successful management of retinal artery occlusion with prostaglandin E1. However, omitting the unsuccessful cases, which is selection bias. It can happen, yeah. In addition to that, the absence of control group and the potential for selection publication bias can also increase these limitations, restricting our capacity to draw a definitive conclusion about the effectiveness and safety of prostaglandin E1 in artery occlusions. So as a conclusion, our analysis revealed prelim evidence suggesting that IV prostaglandin E1 significantly improves visual acuity in patients with CRAO and PRAO. Also, IV prostaglandin E1 was generally well tolerated with a low incidence of adverse effect. So, this profile suggests that IV prostaglandin E1 may be considered a safe and effective treatment option for CRAO and PRAO cases. And thank you all. I hope that I opened the door for further research in the world of central artery occlusion, one of the dismal prognosis conditions in ophthalmology, and I hope I provided new hope, new horizon in these very dismal conditions. And thank you all.